So today we have Dr. Zolnoori presenting. In the interest of time, I'll just let you start with the presentation straight away. Okay,
Okay.
thank you very much, Dr. Zolnoori.
Thank you so much. Thank you so much, everyone, for being here. And sorry for the delay. So we have some issue with connecting with the internet. So the topic for today is focused on a speech processing algorithm for automatic detection of patients with mild cognitive impairment and early dementia. And before I just go to the presentation, I would like to provide some background about my research. So originally, I'm from Iran, and then I completed my education in both Tehran and in both healthcare and the computer science in Tehran University. So part of my research was focused on a clinical decision support system for early detection of childhood asthma. And because of that work, I got a scholarship from Indiana University. So at Indiana, my research focus was on developing a natural language processing algorithm for analysis of patient self-reported messages. After that, we got a scholarship from Lister Hill National Center of Biomedical Communication from NIH in 2016 for one-year fellowship, and I attended at NIH. So at NIH, my research was focused on consumer health informatics, and we developed machine learning algorithms and also natural language processing pipelines for analysis of patient self-reported experience for with antidepressant. And also we created a machine learning algorithm for early detection of patient at a risk of medication non-adherence. So after that, I joined Mayo Clinic. So at Mayo Clinic, I work with both the Department of AI and also neurology and psychology and psychiatry. So our focus was on developing risk identification model for early prediction of patient at a risk of emergency department visits. We also had some, the psychologists and psychiatrists, they also had some interest in prioritizing patients for a care coordination program that based on the algorithm that we developed. So we implemented the system at the registry system that they had, so to prioritize patient for this intervention. So in 2020, I joined Columbia, and the first research project that we started, it was focused on speech analysis. But the speech analysis mainly for predicting patients, home healthcare patient at risk of emergency department visit and hospitalizations. And as a first award, we got from a School of Nursing and also the Center of AI in collaboration with Amazon company. So there was a some research award that we got, so it was around 150. So we were able to start coordinating the communication between patient and nurses in home care with Dr. Maxime Topaz, so associate professor in School of Nursing. So this is the first project that we did. But then I switched on the using speech for early detection of cognitive impairment because something that I saw, especially in home care, it was that the more than 60 patients, they were undiagnosed, even with Alzheimer's disease. So they had a severe cognitive impairment, but nobody had this diagnosis for them. So we also analyzed the clinical notes and also home care structure data that it was available at VNS Health. But the prediction model that we had, so the maximum performance that we achieved after a lot of, even using advanced machine learning algorithm and also transformer models. So it was 65%. So a score with 65%. So it shows that there isn't enough use of cognitive impairment in the structure data, so in the EHR data and also clinical notes. So something that we decided was that what about if we focus on speech? And in 2021, so there was several articles that were already published, and they use a dementia data bank. So it was a publicly available data set that you can try, so you can build an algorithm. So there were some problems with those algorithms. So for example, when we were discussing in our meetings, we found that the generalizability of the algorithm or the method they were followed, it wasn't really, robust method. So it was just like some practice that they were doing for using that data set. So we decided to get some funding. So the funding that we got, it was a K99R00 award. It was the first funding, and also another funding. It was a A2 collective from NIA, so National Institute of Aging, and we started this one. So as I mentioned, so cognitive impairment is undiagnosed, and this is mostly because the patient do not recognize symptoms earlier, and also there is sensitive biomarkers such as MRI, but the access to this biomarker is very difficult because they are very expensive. So if it is estimated that if we just continue with such a problem, in 2060, we have more than 14 million patients with undiagnosed cognitive impairment and with a cost of $1 trillion. And so there is an unmet need here. And this is that we need a algorithm for early detection of cognitive impairment in a way that kind of slow down the progress toward the Alzheimer disease, and also inform the clinician for adopting early interventions. And we found that speech, so as I mentioned, is one of the strong biomarkers. So it's easy to use speech. You just need audio recording device to record the patient's speech, and then you need the algorithm to pre-process the data and extract the features from that. So this is something that I'm going to discuss today. And we developed several algorithms from 2022 on out, and we tested on different data sets that I'm going, so I selected some of them that I'm going to go through some of this algorithm that we have, and just have some discussion about them. So the first algorithm, so before I just discuss the algorithm, so actually I would like to talk about why a speech is important. And something that we know is that how the first thing that we should know is that how human produce voice. So the human produce voice because of the vocal fold that is located in the larynx. And the vocal folds are two bands of tissue that when the air travel from, let me show it here. So when the air travels from lung, so it opens the vocal fold because of the pressure on them, and the vocal fold will start moving. And this movement so creates a sound, so that we call it fundamental frequency. Let's see. You know, in order to, we have some problem here. So let's see. Yeah, so in order to have an effective speech, we really need that the lips, the tongue, the volume, and the jaw, so is very well organized and very well coordinated with a permanent position of vocal fold. So then we can produce phonemes, and then we have a syllables and then words. So if any problems occurs for these, for any problems that occur in the brain that affect on the coordination of these organs, so then it produces some patterns in the speech that if you have enough sample from the patient with cognitive impairment and compare them to the control group, we can identify those patterns and then create a machine learning algorithm for detection. So when we talk about the speech analysis, they usually refer to the source filter framework. So source is a place that the larynx or vocal fold are located, and filter is an organ, so is a oral cavity, the nasal cavity, that the first sound that was created by a vocal fold movement, so travel from this vocal cavity and oral and nasal cavity, and then generates form and frequency. So form and frequency, they usually range it from F1 to F4. And so about the frequency parameters, there is a range for human that they can hear. So the human as a human, we can hear from the range 2 hertz to 2000 hertz. And you know, this is when for example here some people are able to hear this voice, but when it gets, for example, you see this is for 94 hertz, but this is for 12. For 138, and then let's get longer. So when the frequency increases, so you see that most of the people won't be able to hear it. But about the frequency values, And the range of frequency, so it's measured in hertz. For F0, you can see here, that is the fundamental frequency. The range is between 85 to 255. So women usually have a higher frequency for F0. For F1, F2, F3, and F4, so you see that there is also different range, and women have a higher range compared to men. So an F1, something that measures is a height of the tongue in the mouth, and F2 is related to advancement of the tongue, and F3 is related to coordination between vocal organs, and F4 is related to the vocal cavities. So then you see that, so using this frequency range, it can create a pattern that if, for example, someone cannot produce a phoneme correctly, it will affect the frequency of creation of that specific phoneme or word or syllable. So then we can, if we encode acoustic parameters and these temporal parameters, for example, hesitation, we can identify some patterns related to cognitive impairment. And another concept related to the speech is a spectrogram of the voice. So a spectrogram, if you are familiar with signal processing, you know that. So the spectrogram is a visualization of the frequency parameters and energy over time. And for example, this is a spectrogram of two persons. One of them is a cognitively normal, another one had the Alzheimer, and both of them, they were describing picture description task. So picture description task, something that you can see here, they usually use it as a neurological assessment test, and they show that it affects when people start describing this picture. So it can provide some linguistic clues, especially, and we can also, of course, we can also extract some acoustic clues, but usually neurologists use linguistic clues related to this for early identification of patients with cognitive impairment. So this is a spectrogram of the voice. So you see that, for example, for the person that was healthy, you see there is a more energy. So this something that is green here is the energy in the voice, and also the black parts, they are related to the pauses. So when we don't have any energy, it means that the person stopped talking. So now, as a first algorithm that we developed, it was a speech detect. So a speech detect is an algorithm that we developed based on the literature reviews that we had. So we reviewed 47 articles that was published in the area of speech and MCI, and then we just summarized the result for the speech parameters that they found helpful for early detection. So it was from different languages. Most of these studies, they were conducted in European countries. And so we identified 8 categories, so that they were frequency parameters, voice quality, loudness and intensity, speech signal complexity, rhythmic structure, speech fluency, and speech production dynamic. And the size of the circle here shows the frequency of these parameters that those articles use. For example, the majority of the articles, more than 75%, they use fluency of speech, so as parameter for early detection. So some of them, they use frequency parameters, and also it was very common to use something related to rhythmic structure. But something that we found, it was that the speech dynamic that just kind of measured the communication between two persons and then how they communicate. So it wasn't very common in this study. And the major reason it was because all the data that actually majority of the data that is currently available is because it's only focused on a speech on one person. So they didn't try to audio record the conversation between two people. And also something that we did as a part of this algorithm, we also added a module for visualization. For example, we can compare a sentence that was said by two persons. One of them is cognitively normal here that you see, and one of them is a cognitively impaired. So both of them, they said this sentence looks like it's gonna fall. And you see that for the fundamental and format frequencies, so there was more fluctuation for the patient that had a cognitive impairment, or the patient that has a cognitive impairment, they have more noise in their voice, or they have less energy here. And also the rhythmic structure here is more towards monotonous instead of just has some fluctuation. I mean, fluctuation in terms of to increasing the tone, or just have it. So the tone is monotonous for someone who has cognitive impairment. And this is the pipeline for machine learning algorithm. So we had some data pre-processing and also feature extraction based on this component that I explained. And also we have feature selection and finally feature visualization using SHAP model. And we tested it on this publicly available data set that usually people use it as a benchmark. So this benchmark has a development data set that has about 87 for ADRD. So ADRD is Alzheimer disease-related dementia. So they have a cognitive impairment, 79 for control. And also for validation tests or for the test data set that they had, it was 35 for patient with ADRD, MCI, and 36, they were healthy or cognitively healthy group. And you see that the performance of the system, so there was a F1 score was about 80% compared to the published articles based on this data set was a really good performance. And also we have a SHAP model here. So if you know SHAP model, you know that each point on this SHAP model represents a patient or individual that participated in that sample. And also the values or the color shows the values. So here, for example, in this figure, if the values is, they have a lower value, so then the color is blue. And then if it's a higher value, the color is red. And if it is towards the positive part of the this graph, so then it means that that parameters or that variable, so they push the model towards towards that we detect the participant as for cognitive impairment. But if they are in the negative part, so they push the model towards detecting the participant as a healthy control or that they don't have cognitive impairment. And for example, so here if you see, so you will see that the total length of a speech. So if it is shorter, so the blue color here, then it means that the patient has a cognitive impairment. But if it is red, so it is the opposite part of it. And also we will see that for the hesitation rate and also jitter. So jitter is a fluctuation in the fundamental frequency. And also when we analyze the kind of the error in the error in the performance of the system, so that why the system wasn't able to detect some of the participants or was wrong. So for the false positive and false negative analysis, we found that so some patients that they were, so they had ADRD, but the system diagnosed them as a cognitively healthy. It was because their speech pattern was very, very similar to the cognitively healthy patient. So then it just kind of shows that so a speech is not really always affected in all individuals with cognitive impairment. So that will create a false negative cases in this case. So another algorithm that we developed here is related to the, using transformer models for early detection. And then, I'm sure that all of you know that. So that one of the problem with feature extraction is that it won't create very detailed information from the speech that we want. But if we use transformer model, so it can help us to encode the complexity of changes in the voice much, much better than the feature extraction method. But we have one problem here, and it would be that the result that we have won't be explainable. But it would be great if we combine the result of transformers with a feature extraction method, something that we saw I just explained them. So here, transformer models, something that they developed in the area of speech, so works both on the spectrogram of the voice and also on the wave, so the just actual sounds. For example, this is a format of wave to wake that was developed by Meta company. And so something we should do for transformer models is that so they were trained on a huge amount of data set. For example, for Hubert, so Meta company trained it on the 900 hours of audio data, and Whisper, so from OpenAI, they trained it on more than 680,000 audio data. And then we need to fine tune them. So for example, if we use this dementia data bank, that is a publicly available data, so it contains 10 hours data that we can use at just 10 hours. So it's not a very big size, but you just can help us to improve the diagnosis of transformers. And then we will test it. So something that we found is that because if you use the Hubert, for example, that work on the wave, so then the processing would be very resource intensive and very time consuming. So something that we came up with that it was that if we have an audio file and then we segment it, so we need to find an optimal segmentation size. And then we aggregate the result of each segmentation, so we can improve the efficiency of the system, and also we need less resources to do that. And even it increased the performance of the algorithm. So this is something that we did. So this is for how we use Hubert for analysis of voice. And for that, the optimum size for the segments, it was 14 seconds here. And then after that, we measure the performance of the system at both a segment level and also when we combine the segment for each participant in the sample that we had. So this is a performance that you see, for example, here for the same data set. You see M Hubert compared to the other algorithm. So for example, Wave LLM or Wave 2 VEC, so achieved the highest performance and was the F score 81. So the F score is actually 79.31. So it was just kind of smaller than the feature extraction method that we had. And it was mostly because the sample size here that we have, it was less. So it was kind of a small sample size for the fine tuning. So, and then the next question is that, so what about the linguistic part of a speech? So a speech is not just acoustic. So the linguistic part is also provide very informative clues for early detection of cognitive impairment. That is something that psychologists or neurologists usually use this part. And linguistics, so we can see patient recall ability, lexical richness, semantic fluency, and syntactic level of language. We also have psycholinguistic features related to emotion that we can extract from the voice, so someone that's just talking. And then when we incorporate all of this data together, we can improve the performance of the algorithm. So for example, here this is a result for someone who was describing the picture description task with something that I just showed you earlier. And then if you use, so this is a sharp analysis for highlighting the linguistic cues. And then this is an interpretation from Llama model based on the sharp values. And you see that, so the linguistic, so for example, here we can see some disfluency in the patient voice. This patient had Alzheimer. So, and also there was some repetition in the patient voice. So that's kind of highlighted in this text. And when we compare it to someone that didn't have a cognitive impairment, so you see that the interpretation of the linguistic part was that, so the description is very clear and the lexical richness is really high, and also this person maintained a coherent narratives, so in the description. So here, after we kind of extracted acoustic, linguistic, and psycholinguistic cues from speech from the same data set, so dementia data bank. So this is the performance of the system. So if we add linguistic and psycholinguistic features to the acoustic features, we can achieve this performance. So F1 score, so 18, more than 89. And so this paper was published in 2023. And at that time, it was the highest performance that was in the literature from that benchmark data set. And then finally, one of the major questions that we had, it was that, so instead of asking a participant to come to a lab and then, or just to a research center, and then we record the voice of that person. So how about if we just incorporate this audio recording into a routine clinical workflow? So for example, how about if we just audio record a conversation between patient and nurses in home care and identify those that they have a cognitive impairment, instead of just asking patient to read a sentence, or just or describe picture, or communicate with Alexa. So this is some idea that we thought of it. And then we kind of got, using the funding from National Institute on Aging, so we were able to collect data. And so this is some actually we started collecting data. And for the first challenge that we had, it was that, so the audio recording, because it wasn't part of the workflow in home care, we had to develop a pipeline for audio recording. So we had to find something that is kind of reasonable. The audio recording device for recording the communication between patient and nurses, that both of them are comfortable, and also that recording should have a high quality, especially it's very, very important for MCI detection. And then, so this is something that we did. We talked with we bought several recording devices from Amazon, and then we tested them in a lab setting, and also we gave it to nurses to see that how is their feeling with this recording, and also we talked with patients. So finally we chose this audio recording device here. They call it Ceramonic. So 500. That was had a much higher quality compared, for example, to Apple Watch or to other recording devices that we use. And then using all of the algorithms that we developed so far, we analyze those audio recorded patient nurse conversations, so both acoustic, linguistic, and psycholinguistic cues. And also something that we were able to also analyze, it was the communication between patient and nurses. So that kind of this communication cue, it was very, very helpful for early detection. So this is the early result that we have here. So far we collected 108 patients, so the audio recording. But here, so when we analyzed this data, we had only 47 patients. And 47 patients with 125 patient nurse encounters. It means that for each patient, we audio recorded more than one encounter. And the outcome value was for cognitive impairment detection. And you see that the distribution of the patient that we had. So 50% were Black, 30% were white. And for the insurers, for example, 66% they had a Medicare. And then the model that we built, it was that we had a structured data, right? Okay, sorry, let me first talk about the patient. So the model was first about the patient speech. So we separated the patient speech from the nurse's speech and we built a model. So then we said that now, how about if we combine the nurse's speech with the patient's speech? So maybe nurse's speech, they also had some clues related to cognitive impairment. Maybe nurses, they change their conversation with the patient if they have a cognitive impairment. And then for the third model, we only use the EHR data and clinical note that nurses had. And for the final model, we combine all of them. So you see here, if we only use patient speech, so this is the performance of the system. So the F1 score is 75. If we add nurses speech, so it increased the performance. And the reason behind that, it was that because when, so I can show you in the next, here, that nurses, they change their voices when the patient has a cognitive impairment. For example, they show more sympathy, or you see that they repeat some information, or they talk more about the financial issue or something related to the patient problem. For example, there's a social environment of the patient. So that's why that when you also analyze the communication data and even just the nurse's speech, so it improved the performance of the system. And when we only use the EHR data, so including clinical notes, so this is the performance, so 75.56. So it was almost similar to the patient speech. And if we combine all of them, so this is the performance of the system, we will achieve the highest performance. So it shows that this nurses patient conversation, it has an important clues that is not available in the EHR data and clinical note. And here, when we analyzed, so all of the features, so we combine all of the features from EHR clinical notes and also nurses and patient speech, we found that the interaction between patient and nurses, so this communication pattern is much more informative compared to the EHR data. So, and also the features related to the patient speech, so are here, for example, here, so we see filler pauses and other variables. And finally, about the future direction, so we submitted the R01 grant that is, in November, end of November, that is under review at NIA right now. So and this is because we found that even a speech processing algorithm that developed by Amazon company or OpenAI, so Whisper, for example, they had some biases related to the transcription of or recognition of the voices of Black compared to whites. And also, if you really want to have an algorithm for early detection, I mean, especially with the diversity among Black patients, we need to have enough sample size from the Black patient to have an effective algorithm, I mean, speech algorithm for early detection. Also, something that Columbia Department of Neurology was very interested, it was related to the diabetes prevention program. So they are collecting audio data and also video data that they were also interested in early detection of cognitive impairment using speech in this group of patients. This is something, yes, it's something. And then at the end, so just the key point here is that I mean, to improve early detection of cognitive impairment is very, very important, especially with the new intervention and also medication that they found that if the patient use at the early of stage, for example, MCI, it can slow down the progress. And also, if we want to really have a strong method, so it's a combination of the several data stream is a key point. And so the best method is not for the speech analysis, is not just to ask patient to just add extra work to the clinical workflow or ask patient to do something. So if you want to have it in the clinical setting, the best way is to incorporate this audio recording to the patient clinician recording. So in the outpatient setting, inpatient or home care. And also, if we want to analyze I mean, even for early detection, so we even can analyze the clinician language, so which is a great indicator for early detection. And we have several publications related to this algorithm that we developed. And finally, I would like to have a special thanks to all my mentors from Dr. James Noble from Department of Neurology, Dr. Maxim Topaz from School of Nursing, Dr. Susan Bakken from Biomedical Informatics here, and Dr. Julia Hirschberg from Computer Science, and all the students from Department of Computer Science, and also Center of Data Science Institute that they help with this, and BNS helps all of our collaborators. Thank you so much for your attention. Thank you.
Thank you very much, Dr. Zolnoori. I'm just gonna end the show and stop sharing so that we can view everybody. Check my throat. Okay, perfect. So now's we'll have a couple of questions. So I think we already may have some already on the chat. No, we don't. Okay. Oh yes, no, we do. Sorry. So we have one from Florent. He says, "Thanks for the great presentation. Foreigners that are not very proficient in English, how do you adjust your linguistic scale in AD Screen?"
For the this data set that was shared by NIA for the challenge, it was different languages. So, and something that we use, it was a multilingual transformer models. And when you in multilingual transformer models on different languages, so it learns patterns. So it's a combination of patterns. So you don't have to really adjust it to a specific language. So something that we learned from that challenge, it was that even when you use mHubert and then you train it on Chinese, so Spanish and English, so compared to the Hubert, that is just trained on the English language. If you only focus on English language, the performance of mHubert is more than Hubert. So this is a kind of cross language. So if you have several languages with transformer models, that's and the transformer model should be multilingual. So they should be already trained on different languages. So then it can learn the pattern. So you don't need to really, just by fine-tuning, it will learn pattern. You don't need to do some special fine-tuning for a specific language.
Great, thank you. I see that Adit has his hand up, so feel free to unmute yourself and ask a question, Adit. Thank you.
Yeah, I think Zoe had a question in the chat. We can circle back to me since she got hers in first.
Oh, I see. Okay, perfect. So Zoe had a question, which I'll read out now. Very interesting talk. I'm curious whether there are any current studies or future plans that aim to associate the performance or outputs of speech recognition algorithms for detecting mild cognitive impairment with specific brain regions affected in Alzheimer's disease. For example, can we begin to infer which brain areas might be driving particular speech changes identified by the model?
Yes. Yes, it's a great question. Thank you so much. So actually, we had a proposal with a collaboration with this ADRC center, and our goal was to audio record a speech, patient speech for the Black patient and also Hispanic, something that we submitted. But you know that because of all of these things that happened at Columbia, it was canceled. So we had this plan to audio record, and then because the ADR center, they also collect MRI and also PET scan. So it was kind of possible to connect the speech with different region of brain. But for now, we're just waiting to see that what will happen for the ADRC center. So if they can, if we can continue that study.
Great, thank you. Okay, and Adit, back to you.
Yeah, this was a great talk. It's always cool to see research that deals outside of the HR universe, which I'm a bit more used to. So this was really neat to see. I'm curious as to whether there's any discussion amongst the research team about potentially investigating synthetic data generation. Just because you mentioned for one of the grants, there's a lot of smaller sample sizes when it comes to underserved or underrepresented populations in the audio transcript universe, though I know that kind of raises a bunch of ethical questions since, like, how do you go about generating representative audio data in a way that actually captures what patients with a certain disorder or condition may actually like characterize or demonstrate as like their audio trait characteristics. So I'm just curious as to whether synthetic data was an avenue that was, I guess, one being considered.
Yeah, I appreciate your question. So actually, we finalized the study. So here, I just, because of the time limitation, we just decided to focus on something that kind of they are connected together. So we have this study, we almost completed the data analysis. So we use different data synthesis generation method. So for example, a spec augmentation. So it's a framework for data augmentation that you can use frequency masking, time masking, or time shifting, for example. This is, they call it non-native methods. We there's also TTS, so text to speech, that you can, so the system, a TTS model can learn the speech pattern of, if you give a sample, for example, 20 seconds something to the system, so they can learn the pattern. And then with the data that, with the synthetic data that generated by LLM, so based on the something that learned from the original data. So you can create another speech data, so you can kind of expand the data that you have. Another things that we found very, very helpful, it was voice conversion methods, that if you map the voice of someone in the, in the case group, those that they have a cognitive impairment, and map it to the control group. And based on the MEMC score, so that you pair them based on the MEMC score. So MEMC score is a cognitive assessment test that is kind of, you can, they score for the cognitive assessment. So some data said they have it. If you do this, so we saw it improved the performance of the system by 10%. So for the Hubert, so from 79 to 89. So that was really helpful.
Yeah, that's really interesting. Thank you so much for answering that in detail.
Thank you.
Great. Wonderful. I think we're pretty much at time. So unless anyone has a burning question, we'll call it an end here. Great. And so, okay, thanks everyone again. And thank you,
Thank
Dr.
you.
Zolnoori, for
Thank you
a
so
very
much.
interesting presentation.
Thank you.